There's a mixed feeling about this, with some evidence saying that just repeated nasogastric tubing every 1 to 2 hours will resolve an impaction better than any other additive. But it isn't always feasible to do this in the field. And so I do still reach for things like dialkylsodium sulfosuccinate, which is a fecal emulsifier used in cattle to relieve bloat, but works really well as a fecal emulsifier in horse impactions. Or I will reach for my Epsom and Glauber salts. I do warn the owners that these can be irritating, and I make sure that I limit their use in my protocol. And with the Epsom and Glauber salts, you don't want to use these too often because they can also lead to hypermagnesemia or hypernatremia. Specific colics may also benefit from specific treatments. We already mentioned the benefits of Buscopan for relieving some pain and pressure in gas tympany, but you can also troperize the cecum and give the abdomen more room to reduce that perfusion compromise that might be happening with excessive abdominal pressure, and give the intestine more room to float back into the normal position. In sand colic cases, some practitioners might use psyllium with or without mineral oil to help bind and move things along. There again, there's some mixed reviews about the efficacy of this, but if it works, and it isn't going to cause any harm. With regards to mineral oil though, if there is any indication that this is going to go for surgery, mineral oil and anti-gas should be avoided, and this can really compromise the surgery and the recovery. With a left dorsal displacement or a nephrosplenic entrapment, you have phenylephrine, which might also help if you start lunging the horse to the left. The idea being that you shrink the spleen and you work the horse so that the colon falls off into a normal position. You can also do some general anesthesia and have a few strong hands nearby to try and roll the horse and get the colon to fall out of that nephrosplenic space. But this may not be a typical field treatment, so more popular perhaps in second opinion hospitals. I also want to add in here the use of the good old therapeutic trailer ride. This may sound like a joke, but there have been a lot of colics that have a miraculous resolution after just a trailer ride to the hospital. This is so common for me that I actually suggest clients to drive over some train tracks or gravel roads carefully, but to create these vibrations because it does really work. And it's also true for cases that end up going for surgery that just doing the anesthesia and hoisting them into place might actually fix some displacements, leading to a very nice exploratory surgery that finds no surgical lesions to correct. As a medicine specialist, this is my favorite kind of surgery. Sometimes after all your efforts though, you just don't think a case is going to be resolved in the field, and you need to prepare yourself and your clients for referral whenever there is a welfare concern, meaning that the horse is in pain and not responding to the treatments and sedatives given. This also means that if you have any evidence of a surgical lesion like stack dilated small intestine or a thickened bowel and endotoxemia, you need to tell the owner that it's time to refer or euthanize. I tend to work more in a referral setting and use a 3 strikes and you're out rule. When I am faced with a severe colic and I have given 2 doses of ditomidine within 6 hours, I need the owner to be very clear with me what the next plan is. Are we doing surgery or going for euthanasia? I have had a few cases that suddenly did turn around with whatever was bothering them started to shift, but these cases were already slowly becoming less painful. They were already improving in their perfusion, lowering their heart rate. Without that improvement, I'm not willing to continue. So, you've convinced your client to refer. Now what? In your mind, you should have your top list of differentials